Thank you.
Good morning, everyone. Okay, so I'm just going to try and get situated and so that we know where we are. My name is Nikki Hamilton. I'm the clinical director at Aquila Recovery, which is an intensive outpatient program in Washington, D.C. I've been a counselor for a number of years. I don't want to age myself, but I've seen a lot of things change over the years as far as mental health and addictions. And this topic, can everyone hear me? Okay. I've seen a lot of changes over the years as far as mental health and addictions. I came here from Britain, where I was born, and things were done a lot differently back in the 80s. I came here and found that we were doing a lot of therapeutic community and people were being confronted, and I was traumatized because I thought, oh my gosh, I don't know if I can do this addiction work. But somehow I found my way through rehab back into addictions and mental health. I've worked in St. Elizabeth's Hospital. I've worked for Second Genesis, and now I'm in a clinic which is private, but it is co-occurring. We welcome people with co-occurring disorders. We serve people with co-occurring disorders as well as addiction. And as you all will see when we start this topic, which is very, very, it's very important to me in the work that I do. I'm sure that some of you that if you're in this work, you understand that we cannot not look at the issue of suicidality, how it relates to co-occurring disorders, and how it relates to the people that we serve. And if we're trying to do things differently to make our treatment approach more integrated, that we have to look at some things, and that's what we're here to do today. I'm going to hand you over to my partner. We've been partners for quite some time, doing different presentations at different conferences, NADAC, American Association of Mental Health Counseling. We've done a lot of different things, and this is something that we've really taken our time to look at carefully, so I hope that you benefit from it.
Okay. Good morning. I'm Angel Moss Baker. I have a private practice, and I work also with the DC Department of Behavioral Health as their training specialist. And I kind of landed that role after attending and completing a training in co-occurring disorders and integrated treatment practices. And I think it was a SAMHSA grant that we had, and when the grant ended, I kind of was given the reins, the baton, to continue to train other behavioral health specialists in this field. And I have found, as we say, find your niche. And so I think I found it. I really enjoy, never thought I would teach. My father was a teacher. You know how we say we're never going to do the same thing our parents did. But I find that I'm teaching, you know. I'm also adjunct professor at the University of the District of Columbia. And so in my practice, I treat individuals with co-occurring mental health and substance disorders, in addition to comorbid medical, physical disorders, because they're all kind of related, you know. And so, and I enjoy going around to various programs and conferences to provide training and workshops on different integrated treatment practices related to co-occurring disorders. So I'm happy to be here and know that Nikki was able to make this connection for us. And as she mentioned, we have traveled very many places. I just got back from, well, back in September, I was in Italy and doing a training, and I'm going to Canada in May. So people are really interested in what's happening in our field, in our profession. And a lot of folks say, oh, we work with co-occurring disorders, but are they actually providing integrated treatment practices? And so this is what Nikki and I do. And we go around and we actually help folks and other organizations assess their program and determine their true capacity to implement integrated treatment practices. But you know, we were talking about and we were looking at some of the stats in DC regarding suicide. And we were, somehow or another, the conversation came up about overdoses and suicide. And are overdoses intentional or are they unintentional? And the ball rolled from there. So I'm going to let Nikkei begin, and I'll.
Okay. Right. So one of the things that I found as a clinical director of an intensive outpatient program is that I'm sure how many hands, raise your hand if you work with co-occurring disorders or if you're on the mental health side or the substance use. So a lot of people understand both. Okay. I understand both because I see it every day. The counselors that work for Aquila are presented with, people present with all kinds of addictions, mostly substance use. But then we do have the eating disorders and we have the sex addictions as well. But guess what? You know, under all of that, when all is said and done, they have other mental health issues. And so the other thing that I've noticed over the years, and how many people have noticed how much suicide has permeated our society over the last couple of years. Okay, hasn't it? And it is a reality because guess what? Suicide, if you do mental health, suicide is an expectation. Do you agree with that? Okay. If you do addictions, relapse is an expectation. Except I heard Eric say something about the upcoming training that's coming to do with opiates. Guess what? The nickname, does everyone know what the nickname for the opiates suicide relationship is these days? Is the drop dead drug. Okay, so things have changed. Before, you know, it's not just suicide or hanging or shooting. You know, we've got something that's totally different here, and it's right at our fingertips because of the people we serve. So in order for us to look at this a little bit more closely, we're going to look at the difference between intentional and unintentional death. We have to consider that. We have to consider that because, you know, it would be really, I don't think we'd be doing ourselves a justice if we don't look at how are people dying that come to us for help. You know, how are they just dropping like flies when they come to us for help and they didn't shoot themselves and they didn't hang themselves, but they're putting carfentanil in their body and that's it. Okay? So we're going to look at that. We're going to look at, you know, the 4-quadrant model and how we assess suicide risk and severity in the services that we provide. We have to figure out a way to integrate. And I recently read something about Virginia, you know, and one of the Congress representatives saying, you need to figure out what is going on. Why are all these people in our state dying? What is causing this suicide? Okay. Does everybody know what the general increase in the whole of the U.S. is as far as suicide? The increase, it's gone up. Does everybody know what that is? We'll talk about that in a little bit. But first of all, let's kind of go over some definitions. The importance of this definition, of these definitions, are the fact that we've got to look at things a little differently. We can't look at this, oh, it's suicide because the person cut their throat or they sliced their wrist. We have to look at things, the whole spectrum. You know, one of the things that I also read from Virginia was a mother's account of how things got to the point where her child committed suicide. It wasn't just, oh, I found the person hanging. It was the attempts, okay? We look up there. We see suicidal ideation. We see suicidal plan. We see the suicide, the actual acute deliberate act. All of these things have to be a part of our everyday conversation because of the severity, because of what is going on today. We cannot afford to say, well, that's different. It's mental health. Has nothing to do with addiction. It does. So we're going to be looking at the definitions. Keep those in your mind.
And another reason we have these definitions up here is because you're going to see them and you're going to use these terms when we ask you to do an exercise, right? Because when we're assessing suicide, we have to assess ideation, attempts. And the other thing is looking at suicide, and as I mentioned earlier, there's been this confusion and there's been discussion, even maybe amongst yourselves, about overdose being intentional or unintentional act of suicide. Okay, some of us feel if the person is putting these drugs in their system and they die, that was a suicide attempt. And so we're looking at what that definition is of a suicide attempt, which is a deliberate, non-fatal act or self-harm with intent to die as a result of the behavior. And overdose, taking too much of a substance, whether it's prescription, over-the-counter, legal, illegal, accidental, or intentional. Okay? So there's some differing aspects to an overdose and a suicide. Most time people who are using drugs, they're not using for the intent to die. They're using for the intent, what's their intent? Exactly, to feel better, to quell a pain, emotional pain, or whatever's going on with them. They're looking for a way to feel better, and then they will die. They may die. And then we're also going to be looking at talking about like warning signs. What are some of the warning signs and risk factors that are associated with suicide, and what the protective factors are? And one of the assessment tools we're going to go over with you, these protective factors play an integral part in actually determining whether a person is a high risk, a moderate risk, or a low risk. So here's some of the risk factors. I don't need to go over all of them with you. I'm sure that you are familiar. This just lists some. But, of course, the suicide thoughts or previous attempts, genetic predisposition, very important. A lot of times we'll ask a client, have you ever thought about, had any suicide ideations? And they'll say, no, well, maybe some little bit. Well, have you ever attempted? No. Are you having any thoughts currently? No. We don't just leave it there. We have to ask further questions. Has anyone in your family ever committed suicide or made any attempts? Because we find that if people are coming from a background or a family where family members or significant others have committed suicide, it's almost like an acceptable thing to do. Okay? Well, so-and-so did this, it's in the family, and some folks have had 2 or 3 people in their family that have committed suicide. And so, we have to spend time talking about that. History of violence, spending time in prison, firearms in the home, access.
Before we, I just wanted to add one thing. Substance use. Substance use. I mean, if you see in a little vial a little speck of salt, that is the equivalent of a speck of carfentanil that kills or can kill. And we didn't have that before. Some people, I talked to my counselors when we had a meeting yesterday, and I heard a name and death. And I said, whoa, wait a minute. Death, what do you mean died? I said, I talked to you last week, and you said the person had 15 months without any substance. Yeah, but she OD'd last Thursday. So substance use is a big, huge risk factor. Okay.
So we presented this presentation at the American Association of Suicidology last year, and so we kind of kept our statistics focused on DC. And what we found when we looked at all the other states is that DC had the lowest rate of suicides. in addition, it had the low, we also looked at suicide by a cop, where you do something intentionally for a police officer to shoot you and kill you. And that was even low across the nation. And I think we attribute that to the training that we provide to our police officers. Nike and I have both gone out to the training academy, and we have trained the police officers in co-occurring disorders, appropriate ways to approach individuals who may be hallucinating, delusional, paranoid, under what signs and symptoms, questions to ask about last time they took their medication, last time they used the substance, because certain mental health symptoms can mimic the effects of drugs and alcohol, and vice versa, be it intoxication or withdrawal. All right. So we kind of were pretty proud to see those statistics. Now, I think that you looked up some Virginia stats.
Yeah, so I mentioned earlier about Virginia and the fact that I'm really pleased that the Congress and the governor, they're asking questions. Why do we have suicide? What's going on here? What's causing the increase? Okay. And asked a question about the overall increase in the country is 6.2. Would you say that Virginia is higher or lower? Just guess. It is higher. It is 6.6. Any guesses as to why?
Access to what?
Access to weapons. Okay. Okay. It does count the military, but it also, I don't know if you know this, but 29% of that group are children. The increase is boosted up because of children, and they're getting a hold of the weapons.
And 12% of those children or youth are of the LGBTQ community. So I think that, that's something for us to take into account. They are a population with some needs that may be different than youth of the general population. They're often bullied, many are homeless. It's just a number of things, traumatic experiences that what I call, they experience cumulative trauma. So And here we have the third leading cause of death for ages 15 to 24, suicide. The third leading cause of death for our youth. For adults, ages 25 to 44, seventh leading. 14th leading for ages 55 to 64, and so on. But, I really am focused also, I work primarily with adults, but now I'm beginning to shift my focus a little more to our youth, because access to care and services are different and sometimes not as sustainable as what we have in place for our adults.
Cyber.
Yes.
I've been doing crisis work for about 20 years, and that's been one of the largest decreases in the suicidality of young adults and teens, as the cyberbullying, Snapchatting,
Yes.
social media influence. That bullying doesn't stop at school, now it's pervasive everywhere.
Yes.
It takes on a group normative effect.
Yes.
Right.
Exactly.
I think it's great, like I said, that the governor is interested in this, and it's an opportunity for the community, the behavioral health community of Virginia, to try to help, find some of these answers and maybe come up with some strategies that might be helpful to other places not just in Virginia, but in the country as a whole.
These are the stats in the U.S. We just thought we'd add that in there.
There's a lot of
And
people.
then to compare the drug deaths, more than 64,000 Americans died from drug overdose in 2016. So, you know, are we doing a good job in assessing suicide with our clients? And so, you know, this is the purpose of this presentation today, is to kind of just have you refresh yourselves on techniques and questions to ask. You know, we can rest in our laurels sometimes. You know, sometimes we ask the question, are you thinking about suicide? That's an open-ended question, right? So what's the client going to say? They're going to give us a yes or a no, right? And then it's, well, okay, if it's a yes, do you have a plan? Well, no. So then we just move on, because now there's no high risk, there's no plan, you know. But there are other factors to this, you know, and if they say no, then we just keep going. We don't ask those other questions.
I have a, every month I have a report that I get from my counselors about their caseloads. And one of the things that I have said is that anyone who's using opiates, anyone that's dipping into crystal meth and different designer drugs, and we don't know what happens, any one of these are at risk. You know, I don't want to see a report that looks, you know, all nice and, oh, this is so good, we're doing such a great. If someone is at risk, we need to put it down that this person, yeah, maybe now they've been sober for 3 months, but this woman I'm telling you about from last week, she was 15 months sober. 15 months sober, and all of a sudden, boom, she's gone. You know, so when you say, you know, we need to always, I tell my staff, we're always assessing. We don't do the assessment and say, oh, well, I did the assessment. No, we're always assessing. And then someone says, I have suicidality in my past and all these things we're going to talk about a little later on. I want to know, and I want you to update this particular assessment all the time. And we do that. We have something that people fill out every week, and they send it in, and they tell us what's going on. And sometimes I've had these thoughts. I'm not asking whether you're suicidal. What are the thoughts? I just don't feel like getting up in the morning. Ding. You know, I haven't eaten. Ding. Those are the things I need to know. It's not, I need to know whether I said, are you suicidal? You know, sometimes we need to shift. I've changed a whole lot from when I started counseling in the 80s. And we need to, you know, we really need to get that together if we're going to provide true integrated treatment.
This is just a little more with the suicide rates that we were talking about. The last bullet there, while drug overdoses are still highest among whites in 2016, there were disproportionately large increases of drug deaths among racial ethnic minority groups, particularly among Black Americans or African Americans. Well, there have been several reasons. And one of the things that they did in that study, they looked at particular socioeconomic communities, okay? And those were our largest percentages, where we find that folks either don't have health care or they're not really have access to treatment and care. And also the myth or fact that in the African American community, you know, you pray, you go to church, let God take care of it, right? And it's not about going to see a therapist. Now, there are other cultures and ethnic groups that have the same type of traditions, you know, and those are the groups that we typically find may have higher rates of suicide, mental illness, and a number of other things because of the stigma associated to having these discussions and admitting that these things happen. So it's kept inside, you know, get on your knees and pray, go to church, you know, and everything will be okay.
But hasn't that been the same thing for many years? My question is, what's changed? You know, that we have like a sense of resiliency, but now it's gone up 10%. So my question is, what's changed?
Well, it may be that not much has changed, but you know, we have to take into account where we are in our nation with health care. I mean, that's one of the big discussions that still goes on today. You know, having folks have access to affordable health care. Now, one of the things that you will find if you do some of the research is that some of these rates have gone down with affordable health care, okay? Because people who, and we found that with folks coming into drug treatment, number one, you know, because prior to the Affordable Care Act, AKA Obamacare, adults could not receive substance abuse treatment if they had Medicaid. Youth could, but adults could not. But with the Affordable Care Act, Medicaid expansion, substance use treatment, addiction treatment was included as a health benefit. So we saw the, you know, rates decrease somewhat, you know, because more adults now were getting this Medicaid expansion. They were taking advantage of that program and going into treatment. Typically, when an adult who did not have Medicaid prior to, how did they get treatment? They went to the emergency room, and what did they say? I'm suicidal. So when you would look at the rates of treatment on the mental health side and the substance use side, the mental health side was much higher. You know, we had more ticks on the mental health side because we would tell our clients, hey, you can be admitted if you go in there and tell them you're suicidal and tell them you got a plan, okay?
A couple things. Is there a new language or word for treating the whole person? Because co-occurring is implications of two. So if we're treating a child, a minority child, that's LGBT, and they have juvenile diabetes, and they have depression, anxiety, or trauma, how do we address, is there a word?
That's the word, co-occurring. The two,
Still
Covers,
exactly.
Yeah.
And that's why we moved away from dual disorders. Because when we talk about dual disorders, we're talking about just two disorders.
yeah.
it seems like still there's some mix of language for me because co is an implication of
Co is,
And-
I've got diabetes, I've got I have
I've
depression.
got depression. All those things that you said.
Yeah.
You know, one of the things that I would add to that is that we are behind general health. You know, when I go to my doctor, or, you know, not everyone does this, but when I go to my doctor and I say, I've got this shooting pain down my leg and I think my foot is numb, the doctor says, I think you need an orthopedic consult, or I think you need to go to a neurosurgeon. We're just now getting to that point where we're looking at some other things, but we have to do that in behavioral health. And the outpatient setting, for example, is a hub for that. You come to us and you say, you know, I've got a substance use problem, but you've got depression, and you've got an eating disorder, and you've got all these other things as well. So I'm the primary care as behavioral health. Go and take care of these things and come back. You know, but we have to be that hub. The same way the primary care physician is the hub for general physical health. We have to, and we're way behind. We're not there yet.
The other question I had, when you're assessing a client holistically, and one of the protective factors might be religion, or I'm learning who I am as a culture, as a physical culture, so I may have just discovered a part of my life that I didn't have actively. So that also coalesces with my health and everything else. How do we address that if we're just, I'm not saying that it was dismissed, but if prayer or meditation or some kind of spirituality is not brought into that treatment, if I have a client that's religious and they talk about that being a protective factor, I said, are you journaling, are you walking, are you getting out with friends, are you using your prayer and meditation journal, what are you doing? Well, I've lost faith this week, so is that not a holistic way to look at treating a client?
Oh, most definitely. Yeah. So I hand over here.
let me see if I remember my question now. It's when I had to do the increase, I'm wondering how much the increase in availability of drugs and the type of drugs that are so different in the last 10 years. How much does that influence this increase?
The availability.
The increase in availability and the type of drugs that are available.
Well,
Absolutely.
yeah.
Yeah, absolutely. Absolutely. Because now, I mean, we've upped the ante. I consider myself a technological immigrant when it comes to the internet. But my kids will go on the internet and bloom, 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 and this and that and the other. Well, we've got kids who can look up the chemical structure of Adderall and compare it to the chemical structure of cocaine. If I take this much Adderall, it's equal to an 8-ball. If I do this, so they have changed the game completely. They know. They're on the phone with each other. You know, I'm not getting high. Why am I not getting high? Well, take a little bit of this. Take some Ativan. Take some Ambien. And, you know, top it off with a pint of whiskey or whatever it is. They know this stuff. So when you talk about, you know, the lethal aspects, sure. You know, we weren't dealing with this 10, 20 years ago. So I totally agree with you.
And the other thing we're finding also is the increase in the synthetics.
Exactly.
Okay, the synthetic drugs. So, you know, come on over my house to the lab in the basement and let's see what we can put together.
Right.
One of the things that is happening because of the increase, and especially with the opioids, they're now, we were talking about this, you were saying how
California.
the doctors are being scrutinized who prescribe these opioids. So a lot of doctors are hesitant to prescribe narcotic medication. And when they do, they're doing it very gingerly because the DEA is looking at them.
Right. And asking them and querying, you know, this patient of yours who you prescribe Percocet, you know, OD'd on Percocet plus something else and heroin, explain what's going on. And, you know, those physicians that have chosen to ignore are being fined $1,000 a day. So things have changed. The game has changed a little bit because we have to do something about this. You know, it's a crisis, really.
Yes.
I have a comment about that. I've read a lot in the paper, have seen a lot on TV, and they had a special several weeks ago on 60 Minutes about the many of the doctors pushing drugs in certain areas. There was one thing about one town in West Virginia that was given, my God, per capita, an exorbitant number of medications that were that caused lots of suicides. If not suicides, people became
Addicted.
Yes.
So I'm glad that the social work or the mental health community is getting involved in this, in helping to screen those things.
Yeah.
And even, you know, and a part of that is making our clients aware
Yes.
that they need to be somewhat responsible for their own health.
Exactly.
Right.
It's always good that when we're working with a client, and especially when they're being discharged back to the community, you know, they've been in a safe environment, right? That when they go to the doctor, tell the doctor, I am a recovering alcoholic and addict. So some of these medications that you might want to prescribe for me, I cannot take, you know. Even to say I have an allergy to codeine, you know. Whatever can make it easier for them to be able to disclose this information. But we have to also remember that the stigma is still there, you know. And so we really have to work with our clients to teach them what to say, you know, in those situations. Any other comments, questions? Yes.
So does Medicare cover substance abuse treatment?
Does Medicare cover substance abuse treatment?
Medicare, it only covers certain types of treatment like detox and medically assisted
they do.
treatment. But in terms of like sending someone to a 28-day residential or having them in outpatient, they have to have that supplement Yeah, like the-
like Medicaid,
yeah.
or another product, like a Blue
Like,
Cross or
yeah.
Aetna, something like that.
Right.
And it's interesting you'd say that because there's such a high population of seniors that are addicted to drugs. And a lot of it has been their medication that they're now addicted to.
You had a
Yeah, I'm not sure about like the senior care, but with the Medicaid expansion and all of the private providers that have those plans within the Medicaid expansion down in Virginia, that's all covered in it. And that includes like rehabs as well. And if you don't know if your Medicare will cover rehab, like I've had clients in the past that their type of Medicare wasn't covered by any rehab in Virginia. But if you call, it's like, I forget the name of it, but there's an agency that you can call and they can tell you all the different rehabs in the nation that will accept that form of insurance.
Yeah, and that's good to know because education is key. Just like Angel was saying, at least a lot of the clients I see, they don't know this information, and the doctors don't know either. Yeah, I've had people come to me and say, well, my doctor said if I just drink 2 glasses of wine a night instead of a bottle, I'll be okay, you know? And it's like there's a disconnect, and the more education around what the services are, what we need to do, the better. Okay.
Just wanted to look at the second bullet and just read that. We were talking about overdose, you know, the purpose of this presentation, intentional versus unintentional. So determining whether an overdose was suicidal or accidental or intentional or accidental often depends on the circumstances surrounding the death. Indicators of suicide include previous suicide attempts or sudden negative life changes, such as the loss of a job or a loved one. Suicidal people tend to take far more of a drug than the amount used by a routine drug abuser. And I wanted to read that to you and tell you of, Nike and I had a discussion of a client that had taken an overdose of medication.
Yes, benzos.
The benzodiazepines. Now, she had a doctor that was prescribing like 90 of these pills, right? And she had a history of taking a lot of medication. So she ends up in the hospital. And so we were going back and forth about whether or not that was a suicide attempt or whether or not it was an overdose. And so we came to the conclusion, especially after reading this, that, you know, what were the circumstances, you know? And I think that that's real important that we always look at the circumstances and look at the risk factors involved. Already she's in the drug program, so that's a high risk factors. But then let's look at her protective factors. Did she have any? And if so, how many? So I was kind of leaning on the side of that was a suicide attempt, you know, because of the number of pills that she took. And but she made it through okay, and I think she's doing a lot better now.
Right.
Did you want to add anything to that?
No, I just wanted to say that I think the discussion was if you know that this medication you're not taking it as prescribed. You know, they always say, look at, your medicine, take it as prescribed. That's something that we tell our clients. It's something that the doctors, the psychiatrists will say, I will prescribe this for you as long as you take it the way I tell you to. The minute, especially with benzos, the minute I see that you're doing the 2 at a time, 4 at a time, we will have to find something else because it's so dangerous. So like you said, did she have that education? Yes, she had it. She knew it. And yet she still took that many. And in fact, if I remember, her quote was, I called my friend and told her I'd taken 10, and she said, well, and I said it wasn't working, and she told me to take some more. So she took 34 of those 90 pills and ended up unresponsive to the point where the EMTs and the police came, and I mean, they did everything, and she was not, I mean, they even stuck something in her finger, and all she did was this, you know. So it comes to mind for me that we need to make the distinction, but that doesn't mean that just because it wasn't a suicide attempt, that it's not that the person is not at risk.
Right.
Yeah.
And I just wanted, something came to mind. How many of you have ever worked with a client who has attempted suicide or completed suicide? Okay. What was your first thought? Anybody? What was your first thought? Hopelessness on your end? As the, huh? What did we miss? That's the first
Yes.
thought we have. We
Yeah.
take it on.
Yeah, we do.
So a lot of times we kind of stay away from, oh, this was a suicide, because we feel that it reflects something upon the work that we're doing and that we missed something. Guess what? We can always miss something, okay? Because a lot of times our clients aren't what? Totally honest with us, right? Okay, so we have to remember, we don't want to personalize this, okay?
Yeah, and we don't want to politicize it
Right.
either. We'll talk a little bit more about that.
The ICD code, you go ahead. Yeah.
Okay. So as you can see, that this whole idea of intentional versus unintentional overdose deaths has reached has gotten on the world.
Health Organization.
Yeah. Sorry.
World Health Organization.
Yeah, the World Health Organization is aware and has codes for it. You know, we have our ICD codes, you know, that we know we've got ICD-10. We have ICD codes for accidental poisoning, intentional self-harm, assault, and, you know, undetermined intent. And I also, in our research for this particular presentation, I read an article that said that when they looked at all these different unintentional deaths, they couldn't determine whether they were suicides or whether they weren't. There was, you know, they were like, it's up in the air as to what they are. But for me, if it's up in the air, it's a spectrum, because I'm sure that there would be some that are unintentional and some that were suicides, you know. So for us to like separate them and not look at them all together would be unfortunate. I think we wouldn't be looking at people with the same type of treatment eyes if we are able to separate them. I don't think we should do that.
So looking at your slides, your PowerPoint, and looking at those ICD codes, what's Elvis Presley? What code would you give Elvis Presley? Accidental, intentional, undetermined?
Everyone knows who Elvis Presley is? No, the reason I say that is because we brought people up in the American Suicidology, and
Like,
there were
who?
some young people that are like, who is Judy Garland?
And so we asked this question because we have learned that Elvis Presley had a significant history of substance abuse or addiction.
And documented different, you know, overdoses.
Right. So, you know, where would he fall in this spectrum of these ICD codes? The same thing we could ask about Judy Garland. The ones that we have highlighted: Aaron Swartz, Anna Nicole Smith, Michael Jackson.
Does everyone know who Aaron Swartz is? Okay, so Aaron Swartz a few years ago was like involved in this technology internet scandal, and was told that he was found guilty, had to pay back a whole bunch of money. Really, really young guy, and ended up dead by hanging. So that's very clear, you know, that it was a suicide.
And Judy Garland, what was her story?
She had what?
She just had an extensive history of substance use.
Okay. Yes, she
So
did.
was hers an overdose or a suicide?
That was the one question I was going to ask earlier, is just understanding, because when we were talking earlier, I was like, are you equating overdose to suicide, period?
Yes.
But, you know, and that's what you're doing. You're equating suicide with overdose.
We're saying it's a spectrum. We're saying that, so for Judy Garland, for example, Judy Garland, 1, had alcohol use disorder. 2, what else did she have?
Exactly.
Yes.
Depression.
Depression and something else. She was addicted to diet pills. You know, so she was addicted to diet pills. So was it a combination of the diet pills? Was it the depression? It was all, at some point, all 3 were connected. You know, did she get adequate treatment for all 3, or just for the depression, or for, you know, 2 out of 3? So, yes.
Going back to the diagnosis, using the phrase least restrictive, it seems that just considering a person's record or whatever, unless we have absolute proof that it was a suicide attempt, it seems that we would have to use the accidental poisoning
Okay.
as a diagnosis.
Okay, accidental poisoning. Okay, when we use accidental poisoning, for like in Elvis Presley, wasn't it accidental something?
They had, first they said accidental, then it changed. With Elvis, it changed about 4 times.
Yes.
They had accidental, they had undetermined, they had intentional, they had, overdose. They never gave him suicide.
They didn't, right? But all the things that you're saying, like they talked about the depression, they talked about all the different kinds of pills that were in his system, and I'm thinking, if we're looking at certain things as accidental death and not saying what is going on with this person, that they're putting themselves at risk, not taking medicine as prescribed, mixing alcohol and diet pills. So even if I'm not calling it suicide, I should be looking at, this is risky behavior.
Plus, he had a number of health issues.
Right.
Just like if we look at, Robin Williams, now that one really took me by surprise, because the comedian, anytime I want to look at something funny, I turn on Robin Williams. And so we find him, he hung himself, right? So Robin Williams had a history of addiction and depression, right? Exactly,
Yes.
exactly. He had other illnesses, co-occurring disorders, right? And so, did we miss anything? Maybe, maybe not. But I know prior to his suicide, because a hanging, is that unintentional or is that intentional? That's it, right. So we can safely say that's a suicide. He did go into a relapse prevention program.
Just be right.
Michael Jackson. What would you say about Michael Jackson? Unintentional. Prince, unintentional. Whitney Houston. Okay. And that, right. Okay. And that's where folks are.
Right.
Okay. So they would be with this undetermined intent because we know what? That she had a history of drug addiction. We know what? She had depression. She had a number of emotional things going on. I didn't hear about any physical.
No, but the relation, she had domestic issues.
Right.
So
that could be what? Trauma.
Right.
Okay.
Complicated too, when you said that piece about people aren't always honest with
Yes.
us. Well, the other piece of that is they're not always honest or in tune with themselves. So they can only share what they know. So that makes our job even more important, to be able to flesh out all these things that don't necessarily are boom, 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 but we know all the extraneous variables to be able to find those for them.
Exactly.
Right.
Good point. So, we have a list here. Bobby Christina Brown, Whitney's daughter, Phyllis Hyman, Marilyn Monroe, Don Cornelius. Everybody know? He shot himself. But what was going on with him? He had a number of health issues. He had an aneurysm, he had cancer, he had pain. Oh, who's Don Cornelius?
Soul Train.
So, are you familiar with American Bandstand? So, that was the African American Bandstand. It was called Soul Train. So, who was the commentator, the MC for? Dick Clark. So, he was the Dick Clark. Don Cornelius for Soul Train.
Right.
Yes.
You were going to say something?
I was just going to say, like, for example, Don Cornelius, he had a bunch of health issues. It's important, too, to look at the way health issues affect the person psychologically, you know, because I don't know if he had any mental illness, but, you know, dealing with the long-term illness can affect the person.
Exactly.
Yeah.
You know.
Stress.
Right.
Right.
Depression, anxiety. And when you're in pain, chronic pain, you're going to be, you get depressed. You take certain medications, and if you're taking pain medications, narcotics do what to the central nervous system? Narcotics are a depressant, okay? So yes, and I think we mentioned earlier that we have to take into account the whole person, their medical history. You know, is it acute, is it chronic? What medications are they taking? Because a lot of medications, you know, and some untreated illnesses like syphilis, untreated, a person can have psychotic symptoms. You know, so HIV, a large the HIV population has a large percentage of folks with co-occurring depression.
Right. Right. And we have certain drugs that will facilitate a psychotic episode, you know, and the person may not have done certain things if they weren't, you know, psychotic.
What about the parenting law? How does that affect this? With mental health and physical health? I mean, are we not supposed to be honoring that?
When parity, but when you say,
For instance, the physical
right,
and the mental health, they're separate. They're not separate, they're paired.
Right.
We need to insurance companies and everybody else, and they need to be on board with respecting both.
Yes.
Where are we honoring that?
Well, we can ask that question all day long, you know. But you know what? And what we tell folks is it has to start with us. It has to start with us. My father has Alzheimer's. His neurologist wrote a letter that now he should not make complex decisions. I spoke to his primary care doctor to see if he'd also written a similar letter. He knew nothing about the letter. So that continuity of care does not exist. And they're all in the same group practice. And I'm saying, hey, can you please send this letter to the primary care doctor, to his eye doctor, to his diabetes doctor? Everybody needs to know that he now has this letter. But if we don't become that hubbub and help to coordinate care and provide that continuity, our clients fall through the cracks.
right.
So I'm going to take one more question and then we're going to take a little break, okay?
I just had a comment about doctors. I can't remember exactly what I had heard, but it's kind of like what ranking is an MD in class. And according to MD, it doesn't matter the ranking. But hopefully, if you have surgery, you want to have one that has lots of experiences and at the top of the class.
Yeah.
So I know from other people that have shared this with me, we really need to know what the doctor's background is, and if he knows what he's talking about. And that's so important to get second opinions.
Exactly.
Have you heard of SBIRT? The SBIRT is intervention that is going on in hospitals now to kind of let primary care doctors and doctors know about substance use in particular, because when people present, everybody's doing, and they say, oh, just don't drink so much and smoke 2 cigarettes, as opposed to to do a quick screening to see if this person has a problem and might need some help. And that's why I was saying we're lagging behind, but it is up to us to try to push this out there and, to support what's going on, support the people doing the research and creating the evidence-based treatment, and for us to be pushing it, and to stop saying, well, back in 20 years ago we did. No, we have to do what is now. So it's being able to go out there and tell the doctors and educate them. What do you know about substance use? How many drinks makes a person over the limit when they're driving? All of that kind of stuff. A lot of them don't have a clue. So we have to start, really small.
I also think that it's very important too, because even individuals with mental illness, they can present well, so they can go to their doctor and present stable, and the doctor has no knowledge of this mental illness diagnosis. So again, being able to communicate with all providers,
Exactly.
so they're aware, because if a person has an addiction to prescription pills or has they have a greater risk of being addicted, if the primary care doctor doesn't know that, or whatever doctor they're seeing, and they're just giving them medication. So I think, like you said, as far as having everyone on board and aware of, the diagnosis, even if the doctor is not knowledgeable of the mental illness or the substance abuse, just having that on record so that people aren't being over-medicated would be, really good.
Yes. So do you need a break? Okay. 5 minutes? Okay, thank you. Okay, so the second half, we're going to go into the co-occurring mental health and substance use disorders. And I know another familiar term is dual disorders, but language changes in our field all the time, right? Just like the DSM.
Right.
So we're going to go into the co-occurring. You want to go into the suicide and?
Sure. So if you look at the NIMH report, that 90% of the people who take their lives in the U.S. have some type of mental health issue, whether it's depression or substance use disorder or a combination of these. What would be the, I'm sorry?
Okay, you say 90% of people who kill themselves have mental health issues.
Right.
What would, why would the 10% be suiciding for reasons that have nothing to do with mental health? How are you not, if some having a mental health disturbance, then not have mental health disturbance, you can still kill yourself? What were those circumstances?
I think then that's when we get into the area of unintentional or intentional. That's where we get into the spectrum. Were you intending to kill yourself when you took the 34 benzodiazepines? Or were you intending?
But that would then not be a suicide, so that's not really relevant.
What?
It could be health issues, like someone with a major illness and chronic pain, they want to end their life rather than.
Then wait, like what is it, Dr. Kevorkian type of way? Is that okay? All right, and then when we look, one of the things that we did is that we looked at like major mental health disorders like depression, anxiety, bipolar, and so forth.
PTSD.
And PTSD. And 22% of the deaths by suicide in the U.S. involve alcohol intoxication. All right? And then there's 20% that involves opiates, and that's prescription, heroin, and like I said, you've got the drop-dead drug of fentanyl, you've got the fentanyl, carfentanil, and you've got a stronger one than that too. And what we've been told about carfentanil is that is 1,000 times stronger than just plain fentanyl. So when we look at major depression and suicide and substance use, it's most often connected to suicide, and the risk of suicide is about 20% greater amongst those people that have major depression. So when we looked at the different disorders, we got some information about how many people have alcohol use disorder, how many people have substance use disorder, and how many people have opiate use disorder, and so forth. And those with alcohol and other substance-related disorders are at far greater risk, obviously, because somebody mentioned the fact that you might have a physical illness as well. If you have major depression, do you have an eating disorder? Do you have problems with your health because you're not eating well, you're not sleeping well, and so forth? So all of these kind of like form the whole co-occurring aspect of the suicidality. Okay. Bipolar, again, affects 6.1 million adults in the US, right? And people with bipolar are more likely to have psychotic symptoms and anxiety problems with substance use. And why is that? Why do you think that is? I'm sorry?
Self-medication.
Self-medication, and what else?
Family history.
Family history. Okay. What about the fact that you've got somebody who's bipolar that might have, manic episodes as well? Okay. And then people with bipolar disorder have drug or alcohol addiction during their lifetime. A lot of times, I don't know, what I've seen is that people who have alcohol issues often have another drug that they use as well. It's either a benzo, or it's marijuana, or it's another type of depressant. Isn't that interesting that people with depression use depressants to self-medicate?
And sometimes we call it happy hour.
Yes. Are you okay? Are you okay?
Yeah.
Okay. Mm-hmm.
Also, in bipolar, we have the depressed phase.
Exactly.
It lasts a long time, and it can be a very deep depression. Hard to
Exactly.
treat, hard to get out of.
And then that manic phase, what goes up, what? It definitely
Surely
comes
comes
down.
down.
And that's where we have most of our suicides, is in that when they come down and they're in that depressive state. There have been a large number who also have die as a result of a manic state. A lot of times it's considered maybe unintentional, because of exactly, yeah.
Mm-hmm. That also explains suicide that occurred in
Let me come over here. I can't. I'm gonna let you speak in the mic.
Okay, folks, here I am. I'm thinking that with a drug addict, okay, who may be attempting to do recovery, has done recovery, uses, then experience that kind of significant despair. That, so they're coming back down, and then that window of despair, I messed up again.
Mm-hmm.
And so that increases the risk factor for suicide during that small window. And so that could explain also that person 15 months of clean time committing suicide.
Yes.
And how come that decision or that choice was made. I've tried so many times, and I thought I had it right, and I just don't want to do this anymore.
Yeah, good point. Yeah. That reminds me of that term that people often use. I don't have another run left in me. I don't have it. And to me, I think that is a very telling kind of statement that people make. And a lot of times when they make that statement and they use again and a death occurs afterwards, it's their one last cry for, if you can't help me, I can't help myself, and I don't have any other way of helping myself. So the big A is one of the things, I don't know, but I see a lot of problems with anxiety. And anxiety and benzos equal probably an increase in suicide. because a lot of people with anxiety started taking benzos a long time ago.
And overdose.
Yes.
Unintentional, you know, because the anti-anxiety medications fall in what classification? What drug classification? Benzodiazepines. And benzodiazepines are very dangerous drugs. You know, when folks, just like with alcohol, if someone wants to stop drinking and they are a chronic alcohol user, we recommend inpatient care because they need medically supervised treatment because they can have a seizure, they can go into a coma and die. It's the same with benzos. Benzos is up there with alcohol. So a lot of times folks become addicted to that benzodiazepine because it makes them feel good, it helps them to relax. You know, they're up here all anxious, they take the medicine, they feel better. But then after a while, people develop what? A tolerance to the medications. So now when I can take one Xanax or Valium, now I'm taking 1.5, then I'm taking 2. Next thing you know, I'm taking 4 or maybe up to 6 to 8 a day.
And then I get scared that if I've taken all my medicine and the doctor has said I'm not prescribing anymore, that I'm gonna have the seizure.
Exactly.
Or I'm gonna have something terrible happen to me. So I present at the ER to get one pill, and it costs $1,500 for me to be seen in the ER. So then we've got that system loop going again.
Yes, sir.
I just had one comment about that. I think this report on 60 Minutes talked about that. That a lot of people that are hooked on that benzodiazepine, they couldn't get another prescription. And that caused a lot of them to go to the streets.
Yes.
And to get on, what's the other?
Heroin?
Heroin, yeah. A lot of people have gone from the drugs to heroin.
From one drug to another drug. Did you all hear his comment? Okay. Also included here, the other one is Klonopin. How many of our psychiatric patients, everybody gets Klonopin, you know? Very addictive.
Right. Or the sedative anxiolytics like Ativan and Ambien. It's the same type of effect. Sedatives.
Anxiety disorders, especially panic disorder and PTSD, are independently associated with suicide attempts. Among individuals reporting a lifetime history of suicide attempts, over 70% had an anxiety disorder. Yes.
Just speak briefly on PTSD.
Right now?
Okay, but I mean, I know there are a lot of people that are former military.
Yes.
Not just former military, but other people who have had bad accidents or
Yes.
incidents.
Yes.
I'm certain that's really increased the this
Oh,
whole
most
thing about
definitely.
suicide. Things like that.
Yeah, PTSD, suicide risk is higher in persons with PTSD. Oh, you're welcome. You want to take PTSD?
Yeah, so I mean, we've seen a lot of PTSD, particularly with the military. You know, a lot of people coming back from the military, coming back from war situations, having experienced IEDs overseas, and, you know, the loss of limbs, and family members who've lost their loved ones in the military, the PTSD. A lot of, in fact, there's an association in the military of family members whose loved ones have committed suicide based on their inability to reconcile what they've done when they're overseas, what they've witnessed. I remember there was a story about a young man who came back, needed help, went to get treatment, substance use treatment. They told him he needed to go and get psychiatric treatment first. and then he went to get psychiatric treatment. They said he needed to go back and get substance use treatment first. And what this issue was is that he couldn't sleep. Every time he closed his eyes, he was told to shoot someone, and he was a new soldier, and he shot the person in the, now this all came out much later, but because he wrote to his uncle, he couldn't even tell his parents what happened. But he shot a young kid because he was ordered to, that the kid was dangerous. He shot the kid, and he didn't shoot him, quote unquote, dead. He shot him in the face, and he shot him in the eye. And so when he closed his eyes, all he could see was this kid. And that's all he wanted help with. Please help me to sleep. So he started using drugs, he started drinking. And then he started to use cocaine so he didn't have to sleep. Then if he could stay awake, he didn't have to worry about anything. And he really, really tried by himself because he wasn't getting the help that he needed. And finally, he just hung himself. But he wrote a letter to his uncle who lived out in a different state somewhere and chronicled what had happened. You know, we have a lot of military people in our military who suffer from PTSD and are now doing a lot more about it. You know, they're doing a lot more mindfulness, they're doing a lot more trauma work than they were doing maybe 20 years ago. So I think the military is getting some help. And there are other people who suffer from PTSD, children, women, you know, who suffer a lot of trauma. And these individuals have a high rate of suicide once they're either diagnosed or even if they're not diagnosed.
Yeah. What I wanted to ask you, and then I'm going to get you, and then you, and then you, okay? I wanted to ask you, looking at your clients that you work with, your caseload, so to speak, what percentage of your population has PTSD?
In trauma, I mean, that's just buzz terms.
Exactly.
PTSD or trauma.
So what percentage?
So I would say almost all.
Exactly.
Because they're all dealing with something, that's why I'm working with.
And guess what? It's about the same for women and for men. Our community, our treating community, experience a lot of different traumatic experiences when they're using. Sex for drugs, they may get beat up, raped, men get raped, okay? Men do sex for drugs. So there's a number of things that happens to them, you know, that they may not tell us until they really feel comfortable with us because of the shame and the guilt. But we have to remember that this is an expectation, and I think we said that earlier. It's the same thing we say when we're working and teaching or training mental health providers. Substance use is an expectation. So that means we're encouraging them to screen for it, you know. On the other end, substance use professionals, addiction treatment specialists, it's an expectation that a person has a co-occurring mental health disorder. So you must screen for it. But we have to screen specifically for trauma. PTS, be it post-traumatic stress or be it post-traumatic stress disorder. Because if we do not address the trauma, it's going to be that revolving circle for that individual. And our children experience this trauma. Okay? And a lot of them experience it by what they see at home, in their communities, people being shot in the neighborhood. And nowadays, kids are getting killed. We had a kid that was killed, bullet went through the house. It was a drive-by, bullet went in the house, killed the kid. Now, her classmates are experiencing, you have to bring a crisis counselor in to talk to the kids, right? So they experience that secondary trauma. You know, so, you know, Teresa used to sit here and now she doesn't sit here anymore. Okay, yes, ma'am.
Another point about the military, I had a PTSD, military guy came, and his problem was different than I expected. He was a sniper in Afghanistan, and he was very good at it, but he became traumatized like you're talking about. they first of all had drugs flowing everywhere, and so they did drugs and alcohol when he was upset on the job, so to speak. But he was on there for a long time, 10, 15 years. He comes back, and of course he's got the addiction problem, got PTSD, but you know what he wants to do more than anything? Go back. Because he does not find himself fitting in to this world. And often when people find out, and he was a brute, and when people find out, they step back from him. And he said, that's where my friends were, that's where I was successful, that's where I was good.
Right.
But they wouldn't take him back because he was discharged because of alcoholism. And so, he couldn't go back. And so he had this unique problem. It wasn't just learning how to live with PTSD. He didn't like being home. And that really was kind of stuck about me.
Yes.
I've been working on military bases for the past 10 years, and the active duty military, the rise in suicide on the bases has skyrocketed. And I was not in the mental health role as a federal employee. I was a contractor, and we were called MFLACs, or military family life counselors. And 99% when they would investigate these suicides never went for treatment of any type. They were never seen at any treatment because there's such a double bind in the military. There is still that
stigma.
Not so much even a stigma as I don't want that in my record.
Right.
Yeah,
And
that's right.
because it'll interfere with my benefits, or they'll find me unfit. It's like that with police officers as well. A lot of these people will pay out of pocket if they go to treatment. They pay out of pocket. They don't want any documentation.
Right.
They're not using, there's drugs, it's often alcohol.
Alcohol, yes.
As they do the investigation.
Great, thank you. One of the things that I screen for, because I work with a pretty high-risk population, since there are adults who are survivors of childhood trauma, rape, incest, molestation, pretty heavy-duty stuff. So one of the things that I look for, and addicts too, one of the things I look for is not only depression, but despair. Despair I see as not just an emotional issue, but an existential one. Despair says, I've given up, I have no meaning in my life, it's hopeless, I can't do anything. But when I see someone in despair, then I immediately think of this thing, do a suicide assessment. The other thing I want to share, there's a woman out of the University of Chicago named Rachel Yehuda who's done some really fascinating work. She has studied children of Holocaust survivors and children of 9/11 folks. And with the epigenetics, meaning it's not only environment, but there's literally a genetic passing on that creates a higher risk for trauma, which of course would increase risk for suicide. If you can Google her, she's a pretty amazing woman.
Okay, thank you.
I don't know if everyone got a chance to hear what was said, but the whole idea that just because a certain generation suffers the PTSD directly, there's aftermath PTSD, secondary PTSD that the next generation might experience, or though the family members of that particular person is also affected as well. And then I just wanted to add that when someone is using or engaging in dangerous behavior and they have their children removed and the children are taken away by CPS, that whole experience is traumatic in itself.
Yeah. So this chart here is just a summation of what we just went over with those various disorders, mental health disorders. So with PTSD, they're 4 times more likely to have an alcohol disorder, 15 times high suicide risk, 4 times more likely to use IV drugs, 3 times more likely to have depression. With major depressive disorder, their thing is alcohol and cocaine, 30 to 40% of alcoholics, they suffer with the depression. 90% of those with depression die by suicide, often have a co-occurring substance use disorder. Bipolar, alcohol is the most common drug used. 15% of them, 15% rate of suicide amongst these individuals. Anxiety, alcohol, meds are the most fatal. Medication, the meds most commonly abused by people under 30. So just a little chart, it's like a little cheat sheet, you know, you can put it on your cabinet, your wall or whatever. These are the most common disorders that we see in the addiction treatment world.
Right.
Okay?
About our local VA, it's gotten very progressive.
Okay.
The VA has.
Yes.
They have a PTSD unit.
Yes.
That their treatment team involves a social worker, a psychologist, a psychiatrist, an MD doctor.
Yes.
So every avenue is all looking at the same issue
Yes.
with different lenses. So
Yes.
I would like to see that happen in the private sector as well.
Yeah.
Yes, and it does in some programs. If you look at trauma-informed treatment programs, that's what they do there as well. I don't know if you've ever seen the video Healing Neen. Very good video. If you haven't seen it,
Healing Neen.
Healing Neen, N-E-E-N. Yes, ma'am.
Virginia CSPs are now mandating, they're just putting this into effect, that any person who's been diagnosed with major depressive disorder has to be followed up with the Columbia suicide screening.
Okay.
Oh, wow.
So we're,
Yes.
Great.
In
Yeah.
Columbia, we're implementing that now, and every time the diagnosis gets changed, whether from intake, from psychiatrist, or from reevaluation, if they have MDD, they have to have a follow-up.
That's right.
screening And continual follow-up.
Exactly.
Yeah. You know, that's great, you know, and that's why when we have these type of gatherings, it's important that someone that doesn't know what you know hears that information, because, you know, we're lagging behind, and the more knowledge we have, the easier it is to try to get something that cohesive. They had a big presence at the American Suicidology Conference.
Yes, sir, and then you.
Yeah, the name of that film was Healing
Neen.
How do you spell Neen?
N-E-E-N. N like Nancy, E-E-N like Nancy. Healing Neen, yes.
Need. I was just wondering, I guess get thoughts on the PTSD diagnosis, like for the military, like for the you know, for the jobs where people are snipers, which is like a job that would have an impact psychologically. Like when they do like debriefing, you know, because I would think that job would have a long-term impact on someone. Like what would they, you know?
Well, I would hope they do debriefings. You know, most times when military goes out, just like our first responders for these critical the disasters, there's always a debriefing. You know, now to what extent, I don't know, you know?
Yeah.
But yeah.
I think it's gotten better, like the lady said in the back. It's gotten better. I remember before when I went to a PTSD seminar for the veterans, and they distinguished between how soldiers, Air Force, Navy, and the SEALs react to certain things. And SEALs, you know, they're the ones who have this gash in their side and then pack everything and run. And, you know, the Navy SEALs do it this way. And the soldiers, if they start talking about, oh, I'm emotional, it's like, you know, suck it up. But things have changed since then. You know, now they've got a whole unit to deal with that. Yeah.
I remember serving on a crisis team with Katrina. And our job was to work with the first responders and those that were displaced that happened to be working in the hubbub. And so I heard a lot of stories, right? Heard a lot of stories and saw a lot of things and smelled a lot of things. So I come home and I think I'm fine. And I go to the grocery store. So I've been home about 2 weeks, maybe 3 weeks. I go to the grocery store, come out the store, and all of a sudden there's this whiff of death in the air. And I'm like, whoa, wait a minute, I'm not in New Orleans, I'm here in Washington, D.C. So I go and I call my boss. I say, you know, I think I got PTSD. I don't think I can come to work. She said, girl, get your butt up. Come. Suck it up, right? But it was funny. But, you know, what I had was post-traumatic stress. I didn't have the symptoms exactly from secondary trauma. And I did not have the disorder because, you know, in order to have the disorder, you have to have the symptoms for a period of time, right? Okay. So let's go on. I always like to, it's funny. She said, girl, get your butt up and come on. So we're going to talk about some of the evidence-based practices now. And these are the things we want you to take home with you. And I think one of the things that we notice is that, you know, addiction counselors, they viewed suicide as a mental health issue. At the same time, mental health professionals were not always wanting to treat it because so much of the responsibility of a person's suicide was placed on us. And still is sometimes today. First thing they want to do is what? Look at the records. What's documented, you know? And so, you know, we kind of wanted to stray away from that. But we're finding that if we work collaboratively across the aisle, we can help reduce these suicide rates and overdoses. So here we have Minkoff. Are you familiar with Kenneth Minkoff? Yes. So he has that 4-quadrant model. Love this 4-quadrant model. We use this a lot when we work with organizations and treatment programs for them to help develop their levels, right? So you know you have your ASAM levels, but these they can work in conjunction with the ASAM levels. So with level 1, the locus of care is primarily in the outpatient primary care office, okay? That can be you, me, if you have a private practice. I would be in the locus 1, okay? Or quadrant 1. Quadrant 2, the locus of care, is in the mental health system, still on an outpatient basis, okay? You can have, so that would still be on an outpatient basis. Quadrant 3 is a substance abuse system of care, and quadrant 4 is more for the hospital level of care, okay? More intensive. So as you can see, as you move from one quadrant to the next, the level of treatment services becomes more intensified, okay? And more integrated. Yes, ma'am.
So what would be an example of a level 3 facility?
So a level 3 substance abuse facility could be a partial, it could be an IOP. If it's a partial with residential component to it, it would kind of go teeter between 3 and 4, depending on the services being provided and length of stay. So get yourself familiar with Minkoff's 4-quadrant model. Now, what we've done that makes this more unique for your training experience is we have merged Joyner's risk assessment. Are you familiar with Joyner, with the suicide? He's big in suicide risk assessment. And what he says is high risk, a person is a high risk if they present all 3 factors. Factor 1, desire. Factor 2, capability, and factor 3, intent, okay? So that's D, desire, capability, intent. If they possess all 3, they're considered a high risk, and this is despite the absence or the presence of buffers. Buffers is another word for protective factors, okay? A moderate risk, a person is considered moderate to high risk if they have the desire for suicide and the intent, or if they have the desire and the capability. Yes? Okay, so capability is access. Means, what's your plan? So if they're talking a plan and they have access to it, that determines capability. Moderate to low risk, could be any of these factors that present by themselves. If a person has a desire, they could be absent or presence of any buffers can raise their level of risk. So if I have capability, if I'm capable, right, I have access, and I don't have any protective factors, where would you rate me? How would you assess me? It could rise. I could move to moderate to high risk. If I have protective factors, if I have spirituality, religion, if I have supportive parents, friends, a support group, if I'm seeing a therapist, so I have some buffers, some protective factors, I could stay at the moderate to low risk. Now, does that mean we don't deal with this person anymore? No. What it means is we're always assessing desire, capability, and intent. Because today I may just present with, desire. And next week I could present with desire and capability.
Yeah. For example, I have a client who has a history of suicidal ideation and a couple of attempts, and she decided to smoke marijuana, and then she went on Key Bridge and was going to jump off the bridge, and she didn't, and the police arrived and took her to the hospital. And I asked her, I said, what made you stop? And she said, I looked up and there was a school bus going by, and I didn't want the children that were in the bus to see me jump. So, that might not be something that was significant to everyone, but to her it was, because for her, she valued the fact that she didn't want to do something like that in front of children. So when we talk about buffers and we talk about protective factors, that was a protective factor for her, that she valued, the children's experience, and she didn't want them to see something like that.
About what capable is considered independent of like a gun. Because when you say capable, isn't anybody capable?
Well,
they have access to like a rope, like
right.
ask, you have a rope or
that's capability. So, yeah, to have access is capability. How would you do it?
I have 90 pills of Klonopin. That's capability.
That's capability. I'm capable of doing this. In addition, when we ask questions about, have you ever? Yes, I have. How many times? When was the last time? So a lot goes into looking at capability, okay? Because if I've done it before, I'm capable of doing it again. So it's not just the access to, but it's additional information. But when we hear of a person having a plan, typically that's all they need to get hospitalized. So that's highest on the playing field for capability. Yes, ma'am.
But she's right. Pretty much anybody has the potential to be capable. There's just different levels.
There are different levels. And then there's that intent. Oh, yes.
You can look at capability with a plan. Everyone that wants to kill themselves via suicide doesn't want to do it the same way.
Right.
So you listen to the plans, and then you see if they have access to that plan. That's together. That's probably what your question is. That's capability, because any of us can go to Walmart and get a bottle of pills, but everyone that wants to kill themselves doesn't want to do it via overdose.
Right.
So you connect the two, and that helps you with capability as well.
Yes. So then we have kind of put together the levels of care, ASAM levels of care, and I think someone was asking about that earlier. 4-quadrant clinical integration suicide assessment model. And it's entitled the Mosselton, because Nikki and I plan to write this up. So it's my last name Moss and part of her last name of Hamilton, right? And so what we did was put together the ASAM levels of care with Minkoff's 4-quadrant model and Joyner's risk assessment. And so when we look at level 1, we say this is the outpatient level, right? The PCP, the private practitioner, less severe mental illness, less severe substance use disorder. This is the person that can get treatment on an outpatient basis. That can be an IOP, it can be outpatient. With Joyner, we're looking at a person that has desire, just one of them, desire or capability or intent, one of those individually. In quadrant 2, we're looking at the person who has a more severe mental illness and a less severe substance use disorder. The ASAM level of care that coordinate with that would be PHP, it could be an more intensive IOP, and it could also be an OP. Here with Joyner, we're looking at this would be the person who has desire and intent or desire and capability. This is the person that may not have to go into the hospital right now, okay?
Because they have a plan and they've worked on a very solid safety plan, which, for example, in my agency, if we had someone like that who had the desire and intent or desiring capability, then the protocol is then you do a comprehensive assessment and you get much, much more information than you would if a person didn't have any of that.
And remember, we look at the buffers or the protective factors. Are there any there? Are there not any there? Now, a person that would be absent of those buffers would move definitely up the scale for from being low to moderate to high, or high to, yeah. In quadrant 3, this is the person with severe substance use disorder and a less severe mental illness. So they're being treated, remember, in the substance use system of care. That's the person that could be in residential. They could be in a PHP, be it with residential component or without, and they can also be in an IOP. When you look at Joyner's risk assessment, this is the person who has all 3, desire, capability, and intent. The same thing for level 4. That's the person with a severe mental illness and a severe substance use disorder, okay? They're usually in the hospital, in the ER, in residential care. Sometimes we find them in prison, okay? Joyner's assessment, all 3. Y'all like the Mosselton? And yes.
Another thing, back to the capability, I think about, I've worked with people who had desire, and they had access, but they would say, I just can't do that to myself, I just can't do that to my family. So it seems to me that it needs capability from that existential thing, as well as access. Capability by itself just doesn't work.
Right. And what you mentioned in describing that was, I can't do that to my family. That was one of the protective factors. That was a buffer.
I know, but for them it meant it wasn't. We see it as protective. They see it as a part of who they are.
Yeah.
And it's much more internal
Yes.
than just the way we see it as a buffer, family buffer.
Question, when will this go up on the web so we can pass it to our colleagues?
It's probably going to take us a week.
Okay,
Yeah.
thank you.
This is just a breakdown.
On our website, you'll be able to see it on.
Okay.
What we provided here, the next 4 slides, is just a breakdown of Minkoff's quadrants, okay? And we had a case study for you. We can still pass it out and just ask, because I think we're about out of time, and just ask that, in your own leisure, you know, look at the case study and then make a determination for yourself which quadrant in the Mosselton 4-quadrant model, where would you put that client for? Where would you recommend them or assess them for appropriate care? All right. Thank you very much.
All right.